My name is Pankit Chetenkit from College of Sports Science University.
Good morning, everyone. My name is Dr. Dinesh. I'm a sports medicine consultant from Singapore.
And I think right now, we know already, right? Muscle and tendon is weak hormones, and it's still need to do diagnosis, the treatment, and of course for the reconditioning, make them come back. So today we're gonna see what is the evidence-based and common clinical practice. The first lecture today we're gonna start with the most common injury one that we found in the clinic. We found like the hamstring injury around the knee. Repair or rehab it. Please welcome Dr. Akarawin Chorrojprasert. Please welcome.
Good morning, everyone. My name is Akarawin Chorrojprasert. I'm a Sport Medicine Fellow at Bangkok Academy of Sports and Exercise Medicine, Bangkok Hospital Headquarters. Today, I will be discussing hamstring injuries around the knee, specifically addressing the questions: should we repair these injuries or should we just rehabilitate it? Okay, so before going further, I would like to clarify terminology. In the literature, there are multiple definitions of what constitutes a hamstring injury around the knee or distal hamstring injury. Some authors define distal injuries based on proximity to the knee joint, others based on tendon insertion, and some include the entire distal half of the muscle belly. For the purpose of these presentations, I define distal hamstring injuries as an injuries occurring distal to the distal musculotendinous junction. This cut point allows a clearer distinction between injuries that behave more like a muscle strain versus those that behave as structural tendon injuries, which is critical for management decisions. So distal hamstring injuries are uncommon, which only contributes to 2% of all hamstring injuries, but they are clinically challenging. Many of these patients experience treatment failure or delayed return to sport. This is partly because while clear guidance exists for proximal hamstring avulsions and medial muscle part, there is no equivalent guidance for distal or around knee injuries. As a result, these injuries are often treated empirically using borrowed protocols designed for proximal or medial parts, which may not be appropriate. That uncertainty is the focus of today's talk. The typical mechanism includes the shooting a goal, sprinting, or rapid accelerations. Biomechanically, these injuries occur during eccentric contractions, under false knee hyperextension with hip flexions. These loading patterns concentrate stress at the distal musculotendinous junction and tendon insertions, which help explain why many of these injuries are structural rather than simple muscle strain. So when we look at the available literatures, almost all reported cases involve athletic populations. This likely reflects two factors. First, the injury mechanisms involve high-speed eccentric loading. Second, athletes are less tolerant of even small functional deficits, which bring these injuries to our clinical attention. Understanding who is affected helps frame management expectations for these patients. So, how is it different, the distal hamstring injuries? The distal hamstring injuries differ from proximal injuries in both anatomy and biomechanics. Distally, the tendons have less muscular coverage and are subjected to higher strain. As a result, instability, retraction, and disruption of length-tension relationship have a greater functional impact, particularly in athletes. There's a common misconception is to equate the distal hamstring injuries with hamstring harvest for our operations such as ACL reconstruction, where we harvest the hamstring graft. Hamstring harvest is a controlled procedure performed in a stable environment, which regeneration are favored and predictable outcomes. In contrast, distal hamstring injuries involve tissue damage, hematoma, instability, and occur under high functional demand. This explains why surgery is rarely required after the harvest, but often is needed in athletes with distal injuries, and why outcome frequently is much lower here. Men's option can be broadly divided into non-operative and operative treatment. Non-operative care includes modified rest and progressive rehabilitation, with an emphasis on eccentric strengthening. Operative option includes direct repair, excisions, and tenodesis. So when we examine the literature, there's a clear imbalance in the evidence. Proximal and mid-subsequent hamstring injuries are supported by randomized trial and systematic reviews involving hundreds of patients in each study. In contrast, distal hamstring injuries are only supported exclusively by level 4 case series and case reports, often involving fewer than 30 patients, likely to be due to its rarity. But despite these limitations, several consistent themes emerge. Strain or low-grade partial distal injuries generally respond well to rehabilitation, although there remain risks of failed treatment. Complete distal avulsion in athletes demonstrate a higher failure rate with non-operative care. Importantly, there is no high-level evidence defining absolute surgical indications or decision-making must be individualized. Sorry. So an important conceptual shift is recognizing that hamstring injuries are not a single entity. The bicep femoris, semitendinosus, and semimembranosus functions. There are distinct muscles, tendon units with different anatomy, biomechanics, and injury patterns. Treating all hamstring injuries in the same way may lead to suboptimal outcomes. So the supports the need of the injury-specific and tendon-specific evaluation and management. Several factors consistently guide our management. These include the injury location, the specific tendon involved, severity, stability, and retraction, patient demand, and also the chronicity of the injury. These factors should guide our management decision, not treated uniformly just by the diagnosis of the distal hamstring injuries. So first, we'll start with the bicep femoris. It plays a critical role in the dynamic lateral knee stabilities, particularly during spurring and cutting. High-grade MTJ may also scar or teeter, leading to weakness and recurrence in elite athletes. The initial rehabilitation is reasonable for many MTJ injuries, especially for the low-grade one. However, in elite athletes, high recurrence rates that have been reported and non-operative outcome appears to be inferior in especially the high-grade injuries. So in selected high-grade MTJ tears in athletes, open MTJ repair has been reported. In Kayanis series, he demonstrated 100% return to sport at a mean time of around 3 months with no recurrence. Next would be the distal bicep femoris avulsion. This represents the failure at the insertion point. It's also compromised the posterolateral and lateral stabilities, and healing potential is lower without fixation. So the role of conservative treatment is limited to just the strain and partial injuries. Sparse data suggests residual weakness and delayed return to sport in non-operative cases. So in elite with complete avulsion, anchor repair has demonstrated excellent outcomes. Reported series show 100% return to sport at a mean of approximately 4 months with no recurrence as well. Next, with the semimembranosus, it's certainly quite rare. Contributes to knee flexion, tibial internal variation, and posteromedial sterilities. Its broad distal footprint means that the lot of attachment compromise posteromedial force coupling, and this also has low tolerance for chronicity. A trial of rehabilitation is reasonable for partial injury in low-demand patients. Cases of failed conservatively treated partial tear of semimembranosus in athletes have been reported by Lempinan, when none of the 4 athletes were able to return to sport, though the evidence here is limited and largely consists of case series. The surgical repair is considered for complete tears, instability, failed rehabilitation, or in high-demand athletes. Acute repair appears to allow return to sport, importantly, but chronic cases have much poorer outcomes with much lower return to sport rate. But anyway, importantly, no semimembranosus only outcome percentages are available in our current literatures. Next would be the semitendinosus. The distal semitendinosus is the most commonly avulsed distally. Complete rupture leads to retraction, adhesion, and snapping with pain and functional loss. So initial rehabilitation is also possible. However, in elite athletes, there's a very much high failure rate of around 42%. Successful cases return to sport at around 10 weeks. The surgical indications include a complete avulsion with failed rehabilitations or athletic demand of the function. Options include reattachment, kenodesis, and kenotomy. Surgical outcomes are generally excellent with return to sport between 6 and 15 weeks, depending on the technique and studies. For the surgical techniques of semitendinosis, there's mainly three. One, each surgical option has a different rationale. Direct repair restores anatomy, but depends on the tissue quality and ability to reduce it to the anatomical footprint. Kenodesis preserves the false transmission while avoid poor quality distal tendon. Excision reliably relieves pain but sacrifices the tendon contribution, so it's mostly preserved for the chronic cases with snapping. But no comparative trial exists, so selection must be individualized. Next will be the overall summary table for all tendons. This table summarizes the tendon-specific differences in conservative role, surgical indication, and outcomes. It highlights that distal injuries should not be managed with using a single algorithm. I would like to address reconstituted semitendinosis separately because this represents a distinct biological and clinical entity rather than a variant of native distal semitendinosis injury. So following hamstring LS for operations such as ACL, the semitendinosus may regenerate. However, regeneration does not equate to restoration of normal anatomy or mechanical properties. Multiple imaging and cadaveric studies have demonstrated the reconstituted tendon is often structurally inferior with variable thickness, outer insertion, and a higher proportion of scar tissue. So, this outer biology translates to a lower tolerance for distal injury, particularly in the athletes. Patients often present with persistent pain, snapping, or functional weakness, and the durability of conservative treatment in this subgroup appears limited. For this reason, the threshold for surgical intervention is generally lower compared with the native. So, importantly, the surgical goal for the reconstituted semitendinosus pathology is not anatomical repair, but rather the functional stabilization of false transmission. So kenodesis to an adjacent tendon, most commonly the semitendinosus, has therefore emerged as the commonly used strategy. Direct repair may still be considered in selected cases with adequate tissue quality, while excision is typically preserved as a salvage option. Overall, reported case series demonstrate reliable symptoms resolution and high return to sport. So, this flowchart integrates the decision-making process from the sports evidence we currently have in hand. But disclaimer, this is very important because I won't exaggerate and claim this as a guideline or standard treatment, but rather as a concluded idea and logical management pathway. So my management protocol and framework begins with the clinical assessment and then the MRI. So the partial and low-grade MTJ injuries may undergo the rehabilitation first, but failed case or the case with acute unstable avulsion progress to surgery with procedure selection based on the tendon involved, the chronicity, the tissue quality, and the patient demand. To conclude, the distal semitendinosus, semitendinosus, and bicep femoris, they all have distinct anatomy, biomechanics, and clinical behavior. These differences explain variation in symptoms, failure of conservative care, and surgical indication, particularly in the athletes. So tendon matters, pattern matters, treatment should follow them. Thank you very much.
Thank you very much for a very insightful talk on hamstring injuries. So our next speaker is Dr. Upul Madapula. He is a consultant in sports medicine in Sri Lanka, and he's the former president of the Sri Lankan Sports Medicine Association. So he's going to be talking to us about the contemporary management of tendinopathy in elite athletes.